A topic that's dear to my heart, endoscopic spine surgery, which is, for those not familiar, is basically as minimally invasive as it gets when it comes to spine surgery. Obviously it's not a cranial thing, but it is definitely something that is important. A lot of patients in the community that have degenerative spinal conditions and require help. So it's an ultra minimally invasive form of spine surgery that combines tiny incisions with excellent visualization, and it encompasses discectomies, decompressions, and even fusions can be done via an endoscopic approach. And broadly speaking, there's a uniportal approach which is done through one incision. All the instruments are through the camera port, or biportal, which basically is using both your arms, one arm to hold the camera, the other arm to hold the instruments through two incisions. And this is just a demonstration of the equipment that is currently being used in SA and at the Memorial Hospital. Working very hard to try and get some equipment in the public sector, because at the moment it's only available to the private sector, which is not really fair at the end of the day. And this is the kind of view that we get down the on the big monitor, and the type of incision that we see. We're probably more used to seeing an incision 5 to 10 times the size of that one. So just some brief comments on benefits for patients, the surgeon, and the community at large. For the patient, the results are equivalent to the traditional open approach, but there's minimal destruction to the anatomy getting to the pathology through tiny incisions. There's definitely a reduction in complication rates in terms of infection and CSF leaks in particular. The risk of recurrent disc herniation is the same whether it's an open or an endoscopic approach, but ultimately if you can achieve the same goal with less destruction, faster return to activity, normal life, most people are going to be taking that option if offered. And importantly, the last point there, although it's not routinely done, if a patient is particularly comorbid, won't tolerate a general anaesthetic, and traditionally we're told nothing we can do, there is the option to do it under sedation with local. And in countries, third world countries that have endoscopic options, because of lack of resources, that tends to be the way they go, as opposed to relying on anaesthesia. For the surgeons, we have very good visualization and improved ergonomics. So rather than flexing our neck to look down at the spine, we're standing in a nice erect posture, looking on a big monitor. A particular point is it can make traditionally difficult operations more routine and straightforward. So an example is the far lateral discectomy, which can be tricky, or an obese patient. The size, it doesn't particularly matter in terms of how difficult it is when you're doing an endoscopic approach. And it is highly rewarding, because if you have a patient who comes out with recovery of their leg pain immediately and they're up and about, barely touching analgesia post-operatively, it's very satisfying. And for the health system at large, it definitely is a shorter stay in hospital, and overseas day case spine surgery endoscopic is the standard. And in fact, once we finally get it up and running in the public sector, that's the aim, to save on bed days and help the current crisis that we have on the elective wait list, where we can't book patients because there's no bed for them to go post-operatively. Reduce readmission rates overall because of less complications, and overall cost are certainly reduced, broadly speaking. So where did the journey begin? It began with support from the NRF with Dinning Memorial Neurosurgical Scholarship, as well as some support from industry. So I was able to attend various labs. Initially here, in fact, a colleague of mine from Sydney came here and we did a lab at the Tonsley down south, and then a few visitations, Singapore, Germany, etc., supported by the scholarship and industry. And this was the first group who were involved with the very first case that we had at the Memorial Hospital in late 2022. So far, a total of 80 cases, in fact. Majority lumbar, cervical is also an option, and as we know, cervical posterior surgery in particular is quite an uncomfortable operation, but if you can do it endoscopically, it's a game changer for the patients. So I have been keeping tabs of the outcomes. With any new thing, whether it's a product or a technique. It's not new, broadly speaking. It's definitely gold standard in nations overseas, but in my own practice new, I decided to collect data on the patients, so they all do pre-op questionnaires. We repeat them at 6 weeks and 6 months post-op, and the higher number is a worse baseline status. So you can see that pre-op compared to post-op 6 weeks, there's significant improvement. These are quality of life questionnaires, and further improvement from 6 weeks to 6 months, in fact. So these are sustained improvements. This is another quality of life questionnaire. One particularly pleasing observation, which I didn't anticipate, is although I'd expect the leg pain to improve, because that's the aim, you take the disc away, the neuropathic pain improves, I didn't necessarily expect back pain to improve. So when we counsel our patients, we usually say that your baseline chronic back pain is not necessarily going to get better, even though we're doing a back operation. It's really about relieving the pressure on the nerve. But I think the back pain improves as a secondary outcome from improvement of their leg pain with less destruction to their normal anatomy. They can get back to their normal activities with and get back to core strengthening, etc. So I think it's a downflow effect of the endoscopic approach. And this is again at 6 months. We can see from 6 weeks to 6 months there's further improvement. So it's not like they go backwards after 6 months. I've not had a single infection. Normally we quote 3 to 5%, or CSF leak, again around 3 to 5% is the standard risk of that. Similar recurrent rate of disc herniation. One particular complication or outcome from an operation is this dorsal root ganglion dysesthesia. That's a fairly common, it's not really a complication, but sequelae of operating on a far lateral disc that's irritating the dorsal root ganglion. Because I've done quite a few of these far lateral discs now endoscopically, I have been seeing a 20 to 25% risk of this. Generally speaking, it's transient and recovers after 6 weeks. But it's also a risk associated with open far lateral discectomies. So what's the future of endoscopic spine surgery? So we have created an Endoscopic Spine Society of Australia, of which I'm a board member. And this is so that we stop sending our trainees overseas. We've got enough traction now, other people, interstate in particular, doing endoscopic spine surgery where we can have training in-house. I have been involved with training some surgeons here in Adelaide. Santosh Panus, for example, has shown interest, but there's definitely a lot of interest amongst the community. I think we need to get it up and running in the public sector. It's just not fair that it's only an option for private patients, and it's the way forward, I think, so trainees need to be exposed to it. And importantly, we will look at doing research and publications on the outcomes and interesting findings through the journey of endoscopic spine surgery. So a bit of a plea, although the hospitals have supported the concept of endoscopic spine surgery, every time I submit a business case, knocked back because we don't have funding for it. It's not particularly expensive when you look at other equipments that we pay for, and the benefits are quite obvious. So it has been a little bit of a surprise and disappointing that we haven't been able to get it across the line, but I will be sourcing or actively seeking support for buying the equipment basically, so we can get it up and running in the public sector. So thank you once again to the NRF and for the invitation to talk today, and yeah, we'll take any questions at the end.